Hello, this is Lisa Dulski-Watkins with the Milbank Memorial Fund. Welcome to our multi-payer primary care network monthly topical webinar. We'll get started around 1 o'clock. As a quick reminder, please mute your phone or your computer audio. It'll make it much easier to hear our speakers. Thanks very much. We'll get started shortly.
This stinks. Come on.
Hi, is someone having technical problems? Maybe we can help. Hi, everyone. It's Lisa Dulski-Watkins with the Milbank Memorial Fund. It's just noon Eastern time, and we're going to get started with our monthly topical webinar. Just as a quick reminder, I'd like you to please mute your phone or your computer audio if you are not actively speaking. There is a chat function where you can put your questions in, and there will be ample time at the end of our presentation for people to actually ask questions in live time to to speak on the phone. But in the meantime, please mute your phone, and it will make it much easier for everyone. So it is with great pleasure that I'd like to introduce our colleagues and the topic for today. We're really excited to have a team from the state of New York that has been actively working on a core measure set. And there's a great deal of experience and lessons to be learned from what they have been working on and successfully for so long. So just to walk through the agenda, we have a number of speakers who are going to be talking about specific aspects of the primary care measure set development and implementation, and specifically around the collaboration of the health plans, which is a very important part for all of us as we work collaboratively with our neighbors. So with that, I'd like to turn our event over to Dr. Marcus Friedrich, who's the Chief Medical Officer at the Office of Quality and Patient Safety at the Department of Health in New York State.
Yeah, hi everybody, and welcome to the webinar. It is a big pleasure here, and thank you, Milbank, for putting this on and letting us talk a little bit about our experience. Before we dive into the scorecard, I wanted to maybe, Lisa, we can show the next slide to give you a little bit of the background. This is like a copy of what we call the New York State Health Innovation Plan that was published in 2012, and it's really what I consider like the true north of all our state transformation activities that we since then undergone. The goal was always to improve on the triple aim, but we identified, these 5 pillars. I mean, this is probably nothing new to most of you: improving access, integrating care, transparency for the patients, paying or going away from fee-for-service and promoting population health. And we had certain enablers, these work groups that we were working on. And it was really kind of that put the focus on, not only primary care, but also like the DSRA program that we are applied for and were granted by CMS then 1 or 2 years later. Next slide, Lisa. So this is kind of like a high-level overview. So the DSRA program focused mainly on Medicaid, but included primary care. And then there was this, what we called advanced primary care component. and the SIM testing grant that was given to us first as a design grant and then later as a testing grant in 2015 really allowed us to think about using some of the levers that we had. You see, like one of these is the rate review there, but also using things like the common scorecard and prevention agenda and the value-based purchasing as a way for us to drive mainly like two things. One is the primary care transformation using like a design model that we called advanced primary care. But the second component was always to use also multi-payer payment design component in the SIM grant. And that was something that we, from the very beginning, were speaking to payers across the aisle and included them in our thoughts and also in our discussions right away. The next slide kind of highlights what we call the New York State Pcmh model. NCQA was really gracious to work with us on developing our own New York State model. We moved some of these elective criteria into the core criteria for this model, and they were really helpful in, changing their QPAS online platform to accommodate New York State, and it's been a great success. It allowed us somehow to align on the state level behind a national program, but also align the district program on primary care and the advanced primary care program behind kind of one common denominator, and that was really instrumental. And on the next slide, you see some of the high-level accomplishment. We were able to engage about 2,800 practices with over 10,000 physicians. We engaged health plans, not only regional health plans, but also national health plans active in New York State. And it was really this public-private partnership where the health plans voluntarily participated. And we used most of the money to use what we call TA or transformation agent vendors that help the practices to transform to this higher level. And then, of course, the theme of this talk is the primary care core measure set, which I, as a still practicing primary care physician, still see as one of the major accomplishments by aligning the things that we are doing here at the state, but also what the payers are doing in these regions behind one common core set. And putting away with this measurement madness that we in the primary care field are seeing so often. And with that, I give it back to Lisa. Thank you.
Thank you very much, Marcus. I'd like to introduce our colleagues Pooja Kothari and Scott Hines, who will talk about the primary care core measure set, its development, and nurturing stewardship.
Great, thanks. This is Pooja Kothari. I'm a senior program manager at the United Hospital Fund, which for those of you that don't, an independent not-for-profit working to build a more effective healthcare system for New Yorkers. I've been working with the department and assistant parts of the SIM initiative for the past few years. And one of the areas that we've support on is the core measure set. I'll walk you through the half of the presentation, which is really to talk about the core measure set, what it is and how it was developed. And then Scott Hines will take it from there and tell you a little bit about the stewardship of the core measure set. Next slide. So what is the core measure set? It's a set of 7 standardized quality measures that are aligned with several national and state programs, and they cover 6 domains salient to primary care. The purpose of the is really to reflect the quality of care that a primary care practice delivers to its panel of patients, and the use of it is really to help inform monitoring, quality improvement, as well as primary care transformation. Next slide. So this is the primary care core measure set that was recommended for 2020. As you can see, the 6 domains on the left, so prevention, chronic disease, behavioral health, substance use, patient-reported abuse costs. And within each of these domains, there are several measures, with the exception of the cost domain, where we thought it was important to keep that overall domain, even though there's currently no measures that are part of the core measure set for that specific domain just yet. And it also provides a sense of measures that are endorsed by NQF and that are used in part of several other quality programs as well. There are some HEDIS measures there, measures that are endorsed by other organizations as well. Next.
So Pooja, I'm going to interrupt you just for a second. I'm actually going to mute everybody because there's a fair amount of background noise, and then I will unmute Pooja and Scott. Sorry. Sorry, everybody. I love you all, but I'm going to make everything quiet. Okay. So Pooja and Scott, you actually can unmute yourselves.
Can you hear me?
Yep, yep.
Okay.
Pooja, did we lose you? Pooja, I think you're unmuted. You should be able to speak. Okay, I've unmuted everyone now. Pooja, can you come back online? Hello, everyone.
Yep, can you hear me okay?
Yeah, I can hear you, Scott.
Okay. I mean, I can, Pooja, are you there? I mean, if not, I'm happy to take it from here.
I'm really sorry. Pooja, I'm not sure what happened, but we'll have Scott continue.
Okay, and maybe
we'll work on it in between.
Back in. Yeah, okay, all right. So the reason that we went about developing this core measure set is because, you know, as everybody is well aware, there's this issue with measure proliferation nationally, and that, you know, there's only a finite number of areas that any clinician can focus on at any given time. And so what we really want will also be meaningful yet minimize the report burden, because again, I failed to mention that I'm an endocrinologist. I still practice in addition to being the chief quality officer at Crystal Run, and you know, it is challenging for physician groups to you know, report on, you know, multiple different you know, measures in a measure set. And so what we wanted to do was try to develop measures that were, you know, relevant to the different stakeholders, aligned across, you know, federal and state programs, and that would help to achieve this goal of shifting away from fee-for-service and shifting towards value-based care. And when looking at the measure set, is that Pooja?
Yes, can you hear me?
Yes.
Oh, great. Good.
Perfect.
I'm so sorry.
That's all right.
Please continue.
Sure. So I'll pick up where you left off. So one of the priorities, obviously, of the core measure set is to try and shift away from trying to shift towards value and emphasizing on measures that are relevant to patients so that they can use them to make more informed decisions about their care, and also focus on areas that can be influenced by providers' actions, and as well as trying to align with measures that payers think that are important to them. A majority of measures that currently exist are still heavily focused on structures and processes. And so one of the things that the core measure set attempts to do is to shift towards more outcome-based measures, or alternatively process measures where there's strong evidence that links the process to the desired outcome. Next slide. So as I mentioned earlier, there were two kind of phases of the core measure set. The first was its creation. And so the New York State Department of Health initially appointed a stakeholder work group that was trying to provide strategic direction for the entire SIM initiative. And included in its charge was the development of the core measure set. So there were several activities that were involved in developing the core measure set. There was a review of other national and state core measure set principles and measures just to see what was out there and to get a better understanding of how core measure sets were developed by others. A crosswalk was done to look at alignment to try and kind of move towards measures that were addressing several quality monitoring programs. And then the stakeholder work group deliberated and vetted a lot of the measures, and then finally there was consensus on this core measure set. Once it was developed, the attention focused to the stewardship of the core measure set, recognizing that there needed to be a process for the core measure set to evolve over time. And so thereafter, a subcommittee was formed to help establish an annual review process for the core measure set. And so I think this is where Scott will kind of walk you through how the stewardship of the core measure set happened and what was involved in the annual review process.
Great. So thank you. Thank you for that. We can move on to the next slide. So the core measure set was not meant to be something that was stagnant. It was meant to be something dynamic and something that was evaluated on an annual basis. And the purpose of reevaluating it each year is to see if the measures still meet our goals of being relevant and helping to move the that are more meaningful and more important than the old measures. But one thing that the subcommittee felt fairly strongly about was that we didn't want the measure set to just continue to grow and grow and grow, and that if we were going to propose adding measures, then we would want to remove at least one measure for each measure that was added so that the measure set didn't grow beyond its current number. And so what we would, what we proposed is that we would, again, look at the, measure set on an annual basis and develop a scoring mechanism by which to score current measures and any new measures that were proposed by the committee. And new measures that there were potentially not any measures in. So for example, pediatrics, if there was if you look at the measure set, there are fewer pediatric measures than there are adult measures, or OBGYN measures, or those sorts of things. And if there was a new measure that came along that met the criteria, we wanted a mechanism by which to be able to add those. So if you move to the next slide, this goes through the process that the group developed over the course of its first few meetings to go ahead and evaluate the core measure set. So we had 4 stakeholder groups. So we had consumer advocates, representatives from the payer community, representatives from the provider community, and then folks from the using a scoring tool that I'll show on the next slide. And then each measure would, then get a score, and that score was presented to the full subcommittee for discussion and for voting. And then once that process was completed, the final measure set was then presented to the Department of Health as the subcommittee's recommendation for the core measure set for the following year. And then the Department of Health decided whether or not to endorse that. So if you move to the next slide, this shows the scoring tool. And if you look here, as you can see on the left-hand side, it is broken down into 3 domains: principles, principles are the three criteria that we felt were essential. And that in order for any measure to remain on the core measure set or to be added to the core measure set, they would have to meet these three principles, and that's why these are pass-fail. So they must be relevant to the New York State primary care goals. They must address the quadruple aim of better health care, lower cost, and also the physician experience. And they must be standardized measures. They must be measures that are endorsed by an accrediting body so that it's a standardized measure with standardized specifications, exclusion and inclusion criteria, et cetera. Then you move on to the received a score, and you can see on the right there this, how the scoring goes. And these criteria are ease of reporting, and at the same time, can it be verified by practice? And what the balance we tried to strike here is we wanted something that was easy to report, and the easiest thing to report would be claims data, because it really didn't require any additional work on behalf of the practices to report. But we want to make sure that it can be verified by the practice. So if we're going to just be reporting out on claims data, we want to make sure that the practices can verify that the results are accurate. The next one down is that it addresses a high prevalence or high impact area. So, we wanted the measures to be relating to something that's, prevalent in the community and not something that is be relevant to a very small subset of the population, thus leading the denominator of the measure to be, very, very small. Next would be that it aligns with payer measure sets, and this gets back to what Pooja was talking about earlier, where there's been this rapid proliferations in measures and measure sets, and our goal is to try to standardize this and reduce the variation among the different payers. And so if we can align the core measure set with measures that are in some of the payers, that would be helpful. And then lastly is what kind of measure is it? And again, we want to try to move the measure set away from process-based measures and move them more toward outcome-based measures. And so as you can see on the right-hand side there, outcome-based measures score higher than process-based measures. And then lastly are the key considerations. And is the measure a notable performance gap or an opportunity for improvement in New York State? Is it in an area where the state has identified a gap or a need for improvement? So you move on now to the next slide. And, I think frankly, the biggest achievement of the group was coming up with that process and coming up with that scoring mechanism and having an objective way to really evaluate each measure in the measure set, give it a score, have that score be, have the score be determined by multiple stakeholders, and then have, the full committee vote on whether to keep a measure or add a measure. We then, we're successful in, identifying some gap areas. And we've, to date, completed 2 review cycles and presented those recommendations to the department. So,
sorry.
So I'm glad somebody got excited.
Yeah, somebody's listening, right?
All right, let's move on to the next slide. And you can see here. So it shows here that when we went into the 2018.
Maybe whoever's got the dog barking in the background, go on mute. Whoever's got the dog barking, go on mute.
Yep.
Great. So so you can see here that the 2018 review cycle in 26 measures. And then in 2019 and in 2018, we identified some gap areas. And those gap areas were around pediatrics, excuse me, and utilization. And then in 2019, we started with 26 measures, so down again from the 30 measures that we started with in 2018. We removed one of those measures and added 2 measures from those gap areas. So that brought the total down to 24. So I'm sorry, 25. So again, this was exciting because it showed that we were able to evaluate the measure set, adjust the measure set, but actually ended up with fewer measures, more meaningful measures than we started with in 2018. And these recommendations that were brought to were ultimately approved. So, move on to the next.
This is Sheila Nyquist in Rhode Island, and I just wonder if I could ask a question. Can you hear me?
Yep.
I'm just wondering if in your criteria where you have the scoring mechanism, is there an absolute threshold for when a measure makes it into your list? And along with that, is there ever an instance that you encountered where a measure got a very high score, but maybe there was one element of that where there was a poor score that made it a go or no go? So an example of what I'm getting at is, for instance, the HEDIS ECDS measures, where there's quite a few of them that are, would meet all of that criteria you have on there, except for maybe a lack of connectivity to EHR data that's really needed. And so that makes it a no-go.
Yeah. So the first question about was there a minimum threshold? The answer to that is no. We actually, did talk about that quite a bit. That did we want to have kind of a minimum number where if you didn't surpass that number, then it wasn't even considered? And what the subcommittee felt was that so long as the measure passed those key principles, those 3 pass-fail principles, that the measure set would be presented and discussed regardless of what the score is. Now, that being said, the measures that had the lowest scores were the ones that were looked at with the most scrutiny. And so, they were the ones that were more likely to be dropped, but there was not a below this, it's going to be removed. As far as a measure scoring high and being removed, or a new measure being presented and scoring high and not being accepted, to date that's not been the case, but it certainly could be. Again, the numbers are really meant to drive the discussion and to provide some objective evaluation of each individual measure, but it's ultimately up to the subcommittee to decide whether or not to endorse that measure. Now, when we went through the process, what we found is that most of the measures clustered around a similar score, and there were a few outliers. They tended they made it through, and the ones that were low were the ones that were discussed. And not all of them were removed, but the ones that were removed were in that lower tier.
Great, thank you.
Can you move on to the next slide, please? Okay, great. That concludes my part. Thank you.
Sorry, I had to unmute myself. This is Lisa. Thank you very much, Scott and Pooja. I'll turn it over to Lindsay, who's going to talk about the measure set scorecard overview.
Great. Thank you, everyone. And can you hear me okay?
Yep.
Good. Okay. So as Lisa said, my name is Lindsay Kogan. I'm the director of the Division of Quality Measurement here in the New York State Department of Health, Office of Quality and Patient Safety. And I'm going to talk a little bit about how we operationalized our primary care scorecard. So what the primary care scorecard is it's a subset of our overall core set of primary care measures. So we have this larger core set that Pooja and Scott just talked about. What I'm going to talk about is our scorecard. So what we were able to do was actually operationalize and produce a version of some of these measures. And I'll tell you a little bit about how I did that and what that is. So on the next slide, it talks about just sort of the purpose of having this scorecard. We were looking to have aggregated multi-payer information that looks at practice performance across a consistent set of measures. And I know, I'm talking to you providers, so you know better than anyone. Sometimes the variability of some of these measures that you receive from payers, you may enter into an arrangement with one payer and be looking at a subset of quality measures, and then you'll enter into another arrangement with a different payer, and there's a different set of measures. And so sometimes it's hard to say across your whole practice, across payers, across insurers, what does the quality of care look like? Unless you have really sophisticated data analytics that's able to sort of tell you that, it often can be a real struggle. So this was our first attempt at trying to get that full practice view, and the main purpose was really for monitoring improvement and results necessary for New York State practice transformation. We had hoped that it would be used in other ways, like by payers and VBP arrangements, and to identify areas for opportunities for improvement. We haven't quite gotten there yet. What it isn't, it's not a replacement for other, 5-star or scorecard reports. It's not a gap in care report. So what I'm going to talk about today is really aggregate level information. And again, it's a subset of our primary care core measure set. Next slide. So we needed an interim solution. So in a perfect world, we would have a fully functioning all payer data warehouse where we could kind of just very easily run some queries and come out with practice level results across all of the great data that's submitted in a timely basis and totally complete. Since we're not there yet, what we came up with was a way that we could use already existing data that's being reported to the state annually as a part of their HEDIS reporting. We wanted to minimize burden on providers and payers, and also have a consistency in audited data and have a good feel for the level of effort that maybe went into this, and that we could employ a process that could be used over several years and not just be so expensive and so laborious that we can only do it once and then never do it ever again. So next slide is, so this is what we came up with. We came up with a claims-based version that again is using information that providers are already reporting to us at the state of Department of Health. And we understand that there's a great deal of work that already goes into getting information to these payers. So we really wanted to leverage that. So on the next slide, I'll talk a little bit more visually about how, can you go back one more slide? Great, yeah, this one, the one with the pictures on it is good. Slide number 22. Perfect. So we're leaning heavily on the payers for this. So we leaned heavily on the payers for this because there was an already existing infrastructure there with the payers directly to the state. So the payers report to us in aggregate quality level information, as well as we ask all payers in New York State to give us a patient level detail file. And what that is those are the individual patient numerator denominator, a flat file that rolls up to those aggregate level rates. It's not so important for us to necessarily know who all those patients are. So there's, often unique identifiers that don't link back necessarily to anything because we don't have the APD. But what it does show me is it shows me that patient A falls into this many measures and either meets the numerator criteria or doesn't. And so that rich source of information we've used in many different ways. We put out a host of reports, as well as a healthcare disparities report that looks a little bit more at some of this granular level. But what we're using it for here is we are taking that information in and then re-aggregating it. So we're taking it in across payers. We had the payers add some information to a normal patient level detail file, which is really just patient and all the numerators and denominators. We said, okay, give us what provider that patient's attributed to, what practice tax ID that provider practices in. We asked some additional information about practice sites, and that was, you know, spotty. It was good in some cases and not necessarily consistent. And then we were able to intake that information across all plans, all payers, and re-aggregate it at the practice TIN level. So again, using already existing processes, not going out and asking for additional information from providers. We really just had to have the payers put a couple of additional fields onto data that they were already reporting. And so it was very powerful in that we were able to then come up with a practice level report that showed across all payers, across all plans, you know, their quality performance, and we were able to feed back some benchmarks and targets. We shared this information with our practice transformation technical assistance agents that helped with our transformation of our New York State Pcmh practices, and they were actually able to go into the practices and review this information with them, explain it to them, answer any questions, and so we got a lot of rich feedback through this entire effort. Next slide. So this took us several years to kind of get off the ground. We had a path towards this interim solution. We did some pre-pilot testing with a couple of plans, just to you know, field test. Does this make sense? Are we asking for the information in the right way? Is this possible? And about 5 plans across multiple payers participated in our pilot testing in the winter of 2016. It was a smaller set of measures. I think there was 10 measures in total. I think we have 13 now in total that we're able to get. And then we had full reporting across almost all of the insurers in New York State, -1, so 23 different insurance options, -1 or 2 that didn't. But we've had reporting now for the last 3 years, and we're anticipating our 4th year of reporting coming in August of 2020. So next slide. So this goes over a little bit about the patient attribution approach. Again, just kind of reiterating, this is the information that we asked for the plans to be able to put on for each of these members. So we wanted the member, we wanted to know what provider they assigned them or had responsibility for, where that provider practiced, and then the practice TIN. We allowed MCOs to use their own attribution process. We didn't try to standardize or change things. So that is one thing just to note. In other areas of the country where they're doing this in an all-payer claims database, they will often standardize the attribution approach across, again, to minimize burden and to really look at if this was possible. We didn't want to change too much, so we allowed plans to use their own attribution process. And these were the additional elements that we had them include. Next slide. As far as defining practice site, this was a thorny issue that came up, right? So I'm sure most of you are part of a larger practice group that may have multiple sites affiliated with it, right? So for us, our unit of analysis was that higher level practice group TIN. We had a hard time getting to the practice sites under that. That is, I mean, this is ultimately the holy grail. What we want here is we want to be able to kind of roll up and roll back down, but as you all know, it's incredibly difficult to sometimes be able to do that from a servicing provider or that lowest level to sort of that middle layer and then up. So we stuck for the purpose of this initial scorecard at that top layer. And next slide kind of just reiterates what I just said, is that it was easier to define at sort of the uppermost and the lowermost. That middle layer is a little tricky because in real life, you practice at multiple sites and trying to come up with a attribution to just one is difficult, and it doesn't necessarily represent often how it really works. So that is where we landed, which are our practice level reports. We're at the practice group 10. Next slide. And this just gives you a little bit of an example. So what we did is we were able to push out results, and we did, you know, when you get down to this level, you get to small sample sizes. Using health plan data is great in that it's standardized and easy to pull, but there's also continuous enrollment criteria added onto that, so that can kind of narrow the total number of observations. So we did suppress practices with fewer than 20 people in a denominator for any measure. So that was a little tricky. We had some issues with small sample sizes, but you have issues with small sample sizes with any across all having to do with quality measurement. So those that couldn't necessarily see their practice results still got benchmarks for informational purposes. And so you see we have, you know, certain domains and a measure, your practice's numerator, denominator result, and then some statewide benchmarks that show how your result compares to the commercial benchmark, the Medicaid benchmark, and the Medicare benchmark. Next slide. Another piece of information that we found to be helpful was just a snapshot of how your practice compared with an overall statewide average. And so we had a visual, a bar graph where we showed by measure sort of where your practice fell. Was it in the lower 25th percentile, right in the middle, or the upper 25th percentile? And we gave statewide averages. In future years, we even started to show some trending, you know, how this measure result looks like year over year. And this has been helpful. The trending is the next slide, slide 30. So we gave some line graphs just displaying practice results over time. Again, this was just a way for folks to identify opportunities for improvement. This wasn't being used for payment. It really was used. We did a lot of member checking, so the practice transformation agents went to the providers, shared the information, answered any questions, let us know if this seemed reasonable, if this seemed out of whack with what they thought they should have. We got lots of really good questions. Of course, we can only collect this information once a year. So I think that's the most common thing we heard, was that this information is very old. So it's probably by the time it gets into the hands of the providers, it's 18 months old. So, and I hear that a lot in my line of work is, wow, geez, that was a long time ago, a lot's changed. So, you know, it's not going to be used to track ongoing changes in your practice right now. But it could help you identify trends and patterns that maybe you hadn't seen, get a feel for where you are if you aren't currently tracking this measure, give you an idea of where others are benchmarking against. Something we haven't done quite yet is almost like a peer benchmark. That's another thing that's on our list that might be interesting to kind of look at. Right now, everything is kind of lumped together, which was another common theme that we heard from providers, is I'd really like to know how I stack up against my peers with either similar patients, or I'm a solo practitioner, so how do I compare with other solo practitioners, not against this FQHC, hospital-based outpatient clinic, or things like that. So those are some of the things we heard. I do want to take 1 minute before I wrap up to kind of give you an idea of where we're going. And so on the next slide, our future state of HIT-enabled quality measurement, so this health IT. We really are committed here in New York State to improve electronic clinical data quality, and we really feel like this is our path forward to being able to look at population-level measures. We understand there's still a great deal of work to do, but we are really working incredibly hard in many different facets, especially with our qualified entities. We have, I think, 8 here in the state, although I don't know if Jim is on, he can tell me the correct number. I don't know if it's 8 anymore. But we've really established these qualified entities as verified sources of electronic data. So being connected to your health information exchange in your area is important because we're really looking to drive and pull information from these sources. Lisa, if you could go to slide number 32, that'd be great. Perfect. So what we've done is, in our sort of effort to really expand our ability to harness electronic clinical data. We've just wrapped up a quality measurement pilot to look at our qualified entities' potential to calculate some of these quality measures and feed that information back to practitioners. So kind of removing the state, removing the payers, trying to eliminate some of that length of time that happens between the close of a measurement period and when that information could actually get into the hands of a provider, to understand where you're at before the close of a measurement period so that you might have a chance to actually change care. I mean, that's ultimately where we want to go with any kind of scorecards or feeding information back at this level. And so our guiding principles are just that. And so we have used the qualified entities, and and I can come back at another time and kind of go over our full results of this pilot just closed out. And so we're writing up the results right now. But we're looking to really increase timely performance feedback to practices, and we do want this to be used in more ways. And I know Amy, I think, is going to talk about our regional oversight management committees, our ROMCs, our way to kind of help get this information in the hands of those who might actually use it for payment purposes. So that's all I have for my side. Further questions?
Lindsay, thank you so much. I think we're holding questions hopefully for the last 5 or 10 minutes, so maybe we'll move on.
Great.
You can stay on with us. That's great. So I'd like to turn this next couple of minutes over to Amy Tippett-Stangler and Bob Lepenna, who will be talking about the New York City area payer collaboration as an important part of this process.
Great, thank you, Lisa. As she just said, I'm Amy Tippett-Stangler from the Northeast Business Group, and I was the facilitator for the New York City Metro Area Regional Oversight and Management Committee, otherwise known as the ROMSI, which was a multi-stakeholder organization to help move our goals towards reaching what Dr. Friedrich talked about with the New York State Pcmh model. And we certainly had participating health plans in our ROMSI, and we really separated a lot of our goals to have health plan only meetings. And so when we talked about the primary care core measure set as one of the goals, aligning around a focused set of the measures that you just heard about, we saw this really as a step towards payer alignment, really the building block. And the participating payers at that time really thought this would be a quick win for collaboration, and really chose this goal as the first thing that they wanted to work on. So we had 6 health plans initially providing information, de-identified information about the measures that they were most commonly using at that time on their primary care payment models. So they shared that information, which was in turn shared with United Hospital Fund, and they prepared a crosswalk, and I'll say many versions of the crosswalk, to make sure that all of the information was accurate, and then shared it back with the health plans to get their feedback and input. And in a relatively short period of time, I'll say about 90 days, the participating health plans were able to ultimately agree on a subset, about 10 to 14 of the core measures that you saw on the earlier version of the measure set, to use as part of their payment models for the first phase of implementation, noting that the measure set would evolve over time, as Dr. Hines talked about. This is an iterative process. The plans wanted to make sure to note that, they still had additional measures that they would use. However, they agreed that they collectively would use this core measure set to prioritize the shared measures in their performance-based payments. And I can't, say enough how important that collaboration was with the plans and their willingness to share information. And it really set the stage going forward in reaching agreement for every phase that we needed to go through in order to stand up the New York State PCMH model. And with that, I'll turn it over to Bob.
Thanks, Amy. Hi, I'm Bob Lepenna, Director of Payment Innovation Programs for Empire Blue Cross Blue Shield. It was a pleasure to work with Amy, who has program managed this with the leadership of Dr. Marcus Friedrich. And it was a very interesting time to have a number of payers openly and honestly want to get to a place that we could have agreements that aligned on quality measures. From our perspective, we had built an entire program called Essentials around small groups. And it had, a lot less clinical measures than our larger ACO groups and other value-based contracts. So I kind of brought that in, presented it, others brought their measures to the table. And we, as Amy stipulated, came up with 10 or 14 measures, and we agreed that we wouldn't finite those 14 in an effort to have a little bit of movement within the contracting process, but that we would basically have 10 of those 14 core measures within our agreements. So, from a New York perspective, to have some very large payers at the table and smaller ones, regional or otherwise, agree on something of this magnitude, I think was, a real step forward. I'm not speaking for myself, I'm speaking for my brethren and myself. I think there was a lot of really good back and forth. I think Amy did a great job keeping us in line. And, it was a real, from my perspective, success because we all utilized that core measure approach and the 10 of the 14 within contracts in contracting for the New York PCMH. So from my perspective, just wanted to say, spend a minute to say, I think it was a great process with a terrific end result, and love to see that kind of collaboration continue in a multi-payer fashion, because that's really the only way we're going to move the needle is if we're all together at the table doing it. Thank you.
Thank you, Bob. I'm going to turn this over just for some closing remarks to Marcus Friedrich.
Yeah, thank you. I will be brief. I just want to, again, thank the presenters today, but also say or reiterate what Bob was saying, that, we see a certain shift in attitude from the plans. And one of the good things that came out of this is that plans outside New York, some of the more local plans here are using now the primary care scorecard to use in their value-based payment quality program, and using it as a way to align with, an aligned scorecard. And I think this is like a very positive development away from picking out their own, measures, but saying there is a value in if we measure the same things that the state and this collaborative put forth on the scorecard. And I think that is really, I hope that other plans will also, further adapt these measures in some ways. And ultimately that will benefit, the physicians and nurses and everybody who works in these practices to show some improvement, but also ultimately that the patients will, will benefit from that, because less time is spent on, abstracting and, adhering to, this measure madness that, we had for so many years going on here in the state. So with that, thank you, Lisa, and back to you.
Great, thank you very much. I want to just once again underscore what a really terrific presentation this has been, and thank everyone for contributing and for being able to present such very complicated information so concisely and clearly. Thank you. So with this, I'd like to open it up for questions. I know we have a number of folks on the line who are payers in other parts of New York State as well, and there may be some opportunity to get some feedback directly as they may be in the process of evaluating this for themselves, and obviously any of our other colleagues on the line. So open it up. Well, I'll ask a question. Actually, directed really towards Bob. So you've been part of a number of different collaboratives over the years with, you know, obviously your colleagues in other CPC regions, and obviously now what you're describing in this process that we've heard about today. Could you maybe highlight a couple of things that you saw as barriers and maybe the things that really made a big difference in terms of getting past those as you worked to collaborate and come to agreement?
Sure, Lisa. You know, listen, I think the first thing is we all made a determined effort to check the egos, the size, and our involvement with our current organizations when we got together for the good of all of New York's membership, not just our own. And it was a really great transformation to see leadership sit at a table, not, you know, hold their cards close to the vest, be willing to share information, be willing to analyze that information, and be willing to come together as a multi-payer process to do good and to really refine what we need to move the needle forward on quality in the state of New York. So barrier one was, you know, check your ego or don't show up, and work together. There were a number of chief medical officers, financial leads, payment innovation leads. So it was a really good mixture. The second barrier I would say, Lisa, is that, you know, who do you invite to this and how do you get it working? And ensuring that we had all of the right people at the table so that this wasn't something that took 3 years to do was a second barrier to get over. And I think we got over that pretty quickly. And the third one was commitment. It's a huge barrier for everybody. Everybody's got 2-3 meetings at a time. You know, lunch has gone away years ago, 5 and 6 o'clock meetings. People had to commit, really commit to not only showing up. It could be, you know, I certainly was one of them. Every now and then I couldn't make the actual face-to-face, but I was on the phone. So commit to the meetings and then commit to taking back to our organizations the information that we wanted to look at and refine. And I think once we got that moving under the tutelage of Marcus and certainly Amy keeping us project managed, I think it went extremely well. So those are 3 of the things that I think are barriers that you just need to state them up front. Maybe we're direct New Yorkers and we do it differently, but you know, that's what had to happen to make this happen.
Great, thank you. Any other questions that out there? Lindsay, I'd like to ask you a question in terms of what you think of the importance of the role of the state as a, you know, as a very active and participant in this, and because I think there's that can be problematic as states have so many things that they're responsible for, but this was a huge concerted effort, and just wanted to know if you had a comment about that.
Yeah, I mean, so as far as our role here at the state, I think that we provide really important and valuable information, especially as it relates to benchmarks, right? And especially as it relates to historical performance or being able to sort of leverage our our relationships with all the payers and being able to kind of very neutral party aggregate information and push it back out. That's where I think we have a lot of strengths. Where we're not really strong as a state is this rapid cycle quality improvement. Things always take so much longer when they come through us. So they may be more standardized and they may be cleaner, but if it is 2 years later and it's not relevant to where you are now with your practice, that's where I think having the state involved can sometimes not be most optimal. So that aligns with more of our HIT-enabled quality measurement strategies. We really feel like it's not always our place at the state to do this, but we should really be setting the standards and the guidelines and the best practices that could be achieved much better at a more local level, at a level at which is much more connected to that individual practitioner or practice site.
Great, thank you very much. So it is a minute before the hour. I want to just once again thank our speakers for just a fabulous presentation. These slides will be available. We'll post them to our website. There's just the Milbank Memorial Fund Multi-Payer Primary Care Network pages. I'll also probably send up a follow-up email with the slides attached to them. So thanks to everyone for being part of this, and have a good rest of your day. And we look forward to hearing more great news from New York State and for those who've been inspired by the work being done. Thank you.
Thank you.
Thanks, everyone. Take care.
Thanks, guys.